All right, good morning everyone. Thanks for coming. And I think the topic of today's discussion, as we already said, is the hot topic in healthcare. Even if it doesn't sound like a healthcare topic, but this is what is in 2011. So the topic is cost effectiveness of palliative care. This is what justifies us being around. I mean, it's not the only thing which justifies, but it's one of the things which justifies palliative care as a specialty. The topic obviously is very wide, new, rapidly changing, so it has a lot of dimensions which makes it relatively difficult to talk about. But I'll try to restrict myself to these headings, which first would be why we need to understand a cost-effective palliative care. Second, I'll give you the spectrum of palliative care services. Then we will talk about the real expenditure, what we do at the end of life care. Then I'll be trying to churn through the literature about cost-effective analysis done over the last decade. Then talk about the future, how can we be more cost-effective. Palliative care, by definition, as I said, has a grounded concept that we save money. And this is what answers why we need to be kind of talking about this topic. Further, changing population demographics, we all know, and increasing longevity is increasing the chronic disease burden. Plus, evolving healthcare economics puts the onus on palliative care fraternity to prove its worth in terms of saving money. If you really go back to literature beyond 2000, the early literature has a lot of mixed messages in terms of cost effectiveness from palliative care. But it's not that cost effectiveness was not there, it's primarily because of the poor or limited research methodology which was being used at that time. So we are becoming wiser and it's becoming more effective communication in terms of scientific basis. Recent data, more specifically in the last 5 years, I would say, has been able to demonstrate more clearly the saving abilities of palliative care services. So I'll try to kind of restrict myself to the literature and the articles which are giving clear message with another specific message included to it. So this is just to tell you how palliative care has grown in the United States in last, I would say, 7 to 10 years. If you really see, starting from 2001, the number of palliative care programs have almost doubled, and I'm sure in 2010 it's even more. This tells it's probably a really cost-effective thing, but that's why it's growing. To give you the flavor of spectrum of palliative care services, there are different models in which palliative care is practiced. First one is integrative model. This is a model where the primary care teams like intensive care units, oncology services, and geriatric medicine services, the physician or the healthcare providers in that setting, they kind of involve principles of palliative care in their daily day-to-day care of the patients in their specific settings. In this kind of setting, our palliative care services, per se, palliative care specialists are not really involved. Palliative care could be started as early as in emergency room. The thought behind is that most of the money is spent in the initial evaluation of the person who comes to the hospital. So if we can catch them early, we can really save that money. More typical palliative care services are consultative, where the palliative care specialists work as a consultant and they give recommendation and the typical consultative service. And inpatient unit, the like we have in our department here. Going further, palliative care is actually growing in outpatient field and in community-based palliative or home-based palliative care services, what we have in MGHS health services here. So after getting the flavor of it, the most important to talk about, before we talk even about saving money, we need to understand how much we really spend at the end of life care. To understand that, first thing which is very important, the first message is very important. If you really see, almost 50% of the Americans who die in the hospital, they spend at least some time in last 3 days of their life in ICU, which is the most expensive place in the hospital. So we are spending a lot of money, that tells you. And if you really see the data from CMS, I think the number which I have is from 2001, says almost more than a quarter of every Medicare dollar is spent on end-of-life care, taking care of end-of-life care. Because of this huge burden and expected increase in this burden, lately the researchers have been really interested in analyzing the resource utilization towards the end-of-life care in chronic illnesses. This data, what I'm talking about, is particularly related to a resource utilization in heart failure, and it was published 2 months back in Archives of Internal Medicine. What they did, they actually analyzed almost 230,000 Medicare beneficiaries who died from heart failure starting from 2000 to December of 2007. And when they analyzed the data for resource utilization, they took into different domains, which included all-cause hospitalization, ICU day stays, referral to skilled nursing facilities, home care, hospice and durable medical equipments, outpatient physician visits, and obviously this study was related to heart failure, so they included the cardiac procedure, including cardiac catheterization, and ICD implants, and pacemakers, all the high-end cardiac interventions. And what they found, 80% of the patients, before they die, in last 6 months of life, all of them were actually hospitalized at least once, which tells you it's a lot of, it comes with a lot of cost, or a lot of money expenditure at that time. Another thing what they found in their analysis, that ICU days spent, actually it increased from 2000 to 2007 from 3.5 average to 4.6, which is a big money. If you really see 1 day of ICU, I think it cost around on an average $3,500 to $4,000, which is a big money if you really multiply it by 230,000 patients over 10 years. Interestingly, hospice use also increased. It almost doubled from 19% to 40% during that study period. I mean, despite everything, unadjusted cost for end-of-life care increased by 26%, which is a big jump. When I say unadjusted, I think they were talking total cost, not primarily related to heart failure, I guess. That's what I understood. And what they found, the indicators or the comorbidities like COPD and renal dysfunction and Afro-American black race was associated with increased cost at end-of-life care. As I said, even though the hospice utilization has increased over the time, so they were trying to really answer why the cost has still gone up, because we think hospice per se is a less resource utilization settings when it comes to healthcare. So the reason what they kind of hypothesized was, one, obviously as I said, ICU days were more as we kind of analyzed over 10 years or so, plus the discharges to nursing home also increased. So which is, I mean, if we see, that's also Medicare basically cost, discharging people to subacute rehab after their heart failure or whatever, that's also consuming Medicare dollars. Another study from Alberta, just to support how much we are spending on end-of-life care, it also analyzed heart failure end-of-life care almost during the same time. It was almost going parallel, hand in hand in the neighboring country, and the cost was almost $28,000, which is 5 times per capita use of healthcare expenditure in Alberta for a living person at that time. And they hypothesized that increase in end-of-life care was attributable similarly to increasing comorbidities and older age over the time. This is very interesting finding what they found. Cost of care was double in those who died in hospital compared to those who died in non-hospital settings. And going further, even more interestingly, almost half of the patients admitted to tertiary care centers with heart failure, they express their preference to die at home. So this tells you there is a lot of opportunity to save money here. Going further international, South Korean experience. This was done actually and published in 2010. This was the average medical cost analyzed at end of life care for terminal cancers, and the amount was almost in the same range, around 27 to 28,000 US dollars in last 6 months of their life. Very interestingly, this I found very interesting. DNR orders were, though we would think DNR order would restrict end of life care, but it was not the case. Another province from Canada, Manitoba, found in one study that decedents they constitute almost 1% of the population, but they consumed almost 21% of the total healthcare budget in last 6 months of their life. So it gives you a flavor that we are really spending a lot of money, and it's not a US phenomenon, it's internationally, because as you get closer to the dying, you have to do too many things to save the life at any cost. But palliative care, as a palliative care group, we try to do the optimal things which are really effective and they don't kind of burden the patient at the end of life care. Because sometimes we spend a lot of money, but that's also adding a lot of suffering and burden on the patient in terms of physical and otherwise, financially also. Palliative care per se is usually not a very what should I say, the financially attractive specialty, but it reduces cost by decreasing per diem cost and avoiding unnecessary expenditure. This is the way to look at palliative care savings, basically. And I'll start with a relatively recent analysis done by Morrison and colleagues, and they analyzed, this is, I think, this involved a lot of New York hospitals also, analyzed the data from 8 hospitals having a good extensive palliative care programs, and they analyzed the data from 2002 to 2004. And what they did, they divided the whole study population into 2 groups, one receiving the palliative care and the usual care. And they tried to analyze cost per admission and cost per day of hospital stay. And what they found, patients who were in palliative care arm and were discharged alive had an adjusted net saving of almost $1,700 and indirect cost per admission, and they were saving almost $280 a day. And patients who were in palliative care arm and they died also have the savings which are much higher than the patients who were discharged. They were saving almost 5,000 US dollars as a total cost of per admission, plus if you want to split it by day, saving were almost $370. And further analysis showed the significant savings were coming from pharmacy, laboratory, and ICU care. This is something which make their study very kind of message giving, because what they did, what they call as confirmatory analysis. People might argue, counter argue, let me say that. Okay, palliative care, you call the consult on day 5, which means your most expensive phase of hospitalization, which is from day 1 to 5, is already gone. And now you're coming and saying, okay, palliative care saves money. So this is what they try to do and negate. They answered it well. So they included the mean cost per day before palliative care consult and before a reference day for the usual care arm. And they found the same difference. If they analyzed, even if they included the day before the palliative consult was called. Further, they did another way of the analysis. They say, okay, let's assume we don't call palliative care consult on the people whom we called, and let's try to project their expenditure. And it was matching the actually usual care patients. So I think this is a very strong message which is relatively recent. It has more science and more backing behind it. This is just a same kind of thing. I mean, one liner I would want to add. I mean, we all know that more than 50% of the hospitals in the US with more than 50 beds have palliative care services in one or the other form. Another study looking at palliative care cost saving during acute hospitalization also kind of tuned this, sang the same message that hospital saves almost $280 a day people who are discharged and after the palliative care services, and saves almost $500 patients who die in the hospital. And the analysis were in the same kind of domain. Savings were coming from lower nursing costs, lower pharmacy, lower laboratory, and lower radiology costs. People have not seen palliative care saving only in context of acute hospitalization. As I said, palliative care covers the whole spectrum. As we are growing as a field, we are saying we could be involved from day one to even after the discharge of the patient. So this study particularly looked at the palliative care services reducing the cost during the terminal hospitalization. And this was published, I think, in 2006 in Journal of Palliative Care. Penrod and colleagues demonstrated that palliative care was associated with judicious use of inpatient resources. What they found between palliative care and usual care arm, some differences, that palliative care arm was saving almost $240 a day by direct cost, and ancillary cost, which includes radiology and laboratory, was saving almost $100 a day for the period of stay. And very importantly, palliative care patients were 42 percentage points less likely to go to ICU. Surprisingly, they didn't find any difference in pharmacy cost in both these patients. What I think they have explained about it, as you become closer to end of life, even palliative care physicians use a lot of pharmacy to control the symptom burden, which increases obviously at the terminal hospitalization. More typical palliative care services include consultant and inpatient unit. So people have looked the worth of inpatient palliative care unit also separately. Whites and colleagues published data almost during the same time, which Penrod and colleagues did, in which they examined the non-clinical outcomes of opening and operating an inpatient unit during first 4 years of operation. And they could clearly show that IPU yielded almost $1 million at the end of 3 years to the hospital. Average daily charges, this is very important conclusion out of their paper. Average daily charges exceeded reimbursement for ICU, but cost was same. Cost on the same population was equal or below the daily charges when they were shifted to inpatient palliative care unit. Typically, they say the palliative care unit cost around $1,500 a day compared to $3,500 to $4,000 for intensive care unit. Another strategy, what they suggested, that admitting palliative care patient directly to IPU rather than transferring them from intensive care unit or from a step down unit to palliative care is another cost control mechanism. If you admit directly them from ER to inpatient unit, it really saves money, and it obviously is self-explanatory. I'll talk some earlier papers in this context. Smith and colleagues also studied impact of palliative care unit on cost of end of life care, and they could really demonstrate 66% lower cost was involved when you transfer the patient from intensive care unit to palliative care unit, and which is very obvious. If you really see the number from 3,500 coming down to 1,500 is almost 60% of the cost coming down. But that was one way. Then the comparison of PCU died patients with matched controls. This is very important. In non-PCU settings, they were still saving almost 60% money. They were able to demonstrate. I mean, though they didn't match all the patients in the study, they matched, I think, subset of 40 patients or so with the non-PCU deaths, and they were able to demonstrate that you're still saving almost 60% of the money. Again, going international, this is relatively recent paper in 2010, South Korean study, which was in relation to, as I said, terminal cancer. And they demonstrated that there was huge saving in last 2 months of life when the patients were admitted to palliative care unit. And if you see month-wise, 1 month prior to death and 2 months prior to death, they were able to demonstrate 33% saving in each month. And palliative care unit was found to be an independent risk factor, independent factor involved in cost reduction by 27% in last 6 months of their life. These were their very clear conclusions, and these were relatively better phrase research papers actually. So when I'm talking that palliative care is great, palliative care unit is great, so this slide gives you just the snapshot of how the palliative care units are distributed all over the country. And as of 2009, we had almost 400 palliative care units, and I'm sure they're growing exponentially every day. As I said, people have looked at every domain palliative care can affect cost reduction even after discharge. This was a very interesting paper which Gade and colleagues did and published in 2008. It was a randomized control trial in which they tried to study the impact of an inpatient palliative care team consultation on patient satisfaction, clinical outcomes, and cost of care for 6 months post-hospital discharge. This was very interesting. And they demonstrated that palliative care patients had fewer ICU admissions when they were readmitted. It sounds very self-explanatory, but people were able to show it scientifically now. So I can say it with more energy. And lower 6-month net cost, when they analyzed last 6 months of their life, irrespective of how they died, they were able to demonstrate they're still saving $5,000 US. And median length of stay in hospice was more for palliative care patients, self-explanatory. Okay, Catalonia. I read about this when I was trying to prepare about this. This is one of autonomous, I think, community in Spain. They have 17 autonomous communities, and this is one of those. And World Health Organization started a initiative which is conceived as end-of-life care initiative in public health system. It was started in 1989. And this group was basically designed to find how palliative care saves money. And they, in 2009, published their 18-year-old long experience in terms of cost savings in end-of-life care. And they were able to demonstrate from 1995 to 2005, palliative care programs contributed to increased savings from 3 to 8 million euros, which is a big money. Okay, this is a very important topic. Palliative care physicians, as of 2011, should never tell to the administrators, we could definitely save or reduce length of stay. This is what this analysis is telling me. This was done by a wonderful review done by Castle and colleagues and published in 2010. They reviewed all the available, papers which are talking about impact of palliative care on length of stay, and they found it's not that it is not affecting, probably it is, but most of the papers are poor in methodology. That's why the message is not very clear. So they suggested that this aspect of palliative care should be analyzed by more, I would say more rigorous analysis, and reporting outcomes should be analyzed separately for survivors and the decedents. Further, they said in their analysis that in analysis we should avoid pre-consult days for analysis, which we always talk about when patient comes to our unit. We say we don't want to talk about the number of days they spent in the hospital before palliative care consult or palliative care services were involved. Secondly, they said very specifically that patients who in whom longer length of stay was a trigger to call for consult, palliative care consult should not be included because they are already outliers. So your data will be obviously giving mixed messages. So these were very important conclusions, and I think as of now we don't have it is there, but as I said, we don't have a scientific paper to support this. Okay. So we have kind of covered most of the recent thought process, how palliative care services are saving money. Now let's see what kind of problems we have in terms of planning research to demonstrate palliative care cost saving effectiveness. I think Dr. Portnoy told us about research methodology lecture that it's very difficult to kind of plan a formally randomized high quality research in seriously and terminally ill patient. That stands true here also. When I want to talk about cost effectiveness in the same population, it makes it even worse because of obviously ethical issues, and people have cultural issues when they are being enrolled onto cost effectiveness trials. So it's self-explanatory. Plus there is another aspect to it. If you really see, not everybody is as lucky as we are. In our department, we have all the domains of palliative care. If you try to analyze the composition of palliative care teams all over the nation and even internationally, not everybody has all the domains which typically a palliative care service should covered. So that makes it even difficult to kind of have a multi-centric trial on a larger population with more variability. So it's like comparing oranges and apples when you try to compare those different compositions. Still, many healthcare physicians and families confuse palliative care services with hospice, which is seen as kind of, giving up. It's their mindset. I think it's this can be done more with education from palliative care leaders. Okay, as I said, 2011, everything is about money in healthcare. Not that people are becoming greedy, but we are living in a relatively resource limited setting, and the burden of chronic disease is increasing. So that's why money is very important. So the cost effectiveness data which we are trying to collect or will be collecting in future has to answer these important questions: impact of palliative care on length of stay. And when I say that palliative care saves money, administrators or the hospitals would like to know how would you kind of compare the inbuilt expenditure which I have to do to set up a palliative care programs, including administrative cost and the salaries of the staff involved in the palliative care. I think future, as I said, would be very promising if we can identify palliative care interventions which are most effective economically, and then study and collect data on those interventions rather than just collecting data. So to conclude, I'll say costly does not always mean the best care. As I tell my son, costly toys are not safe, which is a different reason. Cost effectiveness analysis of palliative care is a relatively recent phenomena. Despite difficulties in predicting trajectories in advanced illnesses, for effective palliative care services, discussion about goals of care and resuscitation should be started early enough in the course of illness, so that you can really make a difference in terms of cost effectiveness and a best quality care. So palliative care cost saving analysis should be multifaceted rather than a single analytic approach. When I say, let me try to explain this a bit more. When I say, okay, moving patient from ICU to PCU save money, but at the same time, I'm generating a new bed for a relatively new person who can go to ICU. Otherwise, hospitals tend, if their ICU beds are full and the people in ER come and they need ICU beds, they go on diversion. So that is in a way lost to the hospital. One, they lose the continuity of their previous patient, and then the chance of exposing themselves to a new client is also gone. So it's multifaceted. When you try to talk about palliative care cost saving, you have to take into account all those things also. Demonstrating physical benefits for the hospital would be very attractive trigger for expansion of palliative care programs, which are already improving quality of care, patient and family satisfaction. Palliative care thought leaders, Dr. Yeti and Dr. Portnoy, Dr. Lesage, it's for you guys, have to plan better conceptualized research with more discrete and replicable palliative care interventions to demonstrate the efficacy. These are my references. Thank you so much.